Welcome to the Rehab Links Secrets to Success podcast. I'm Lisa Chase, your host, and we have a very special guest this morning, Dr. Ed Isaacs. Good morning and welcome.
Good morning.
So, Ed, I was thinking about when did I first meet you? And it was back, I actually have known you longer than I've known my husband.
Yes, you were living in Chicago at the time.
Yeah. I mean, if this thing is back to like 1996, when I first took the principles of manual medicine and you were instructing, and that's where I was first exposed to you. And then over the years, I just kept taking the courses. You were doing the advanced courses, and eventually I started teaching and principles with you. And then you moved into muscle energy, and I said, well, I want to be in muscle energy. And then just, kept evolving. And we've been teaching together for many, many years now, probably 20 plus years. And, and I can say that, Ed he knows how to make learning fun. Like, I just love learning from you because, you never take yourself too seriously. You always have a great joke to tell. And, we just have fun when we're learning. And Ed comes with a really interesting background. So he started off as a neurologist and had a very successful practice in Virginia. And I can't wait to kind of let you tell the audience your story, but basically he got exposed to manual medicine at Michigan State and it completely changed his practice. So with that, why don't we jump in and you can kind of take us on the journey of Ed Isaacs.
Okay, well, let me start back in medical school. When I started in my first year, I got the opportunity to listen to a lecture by a neurophysiologist. And his story was that he was a ship's steward during World War II. He hadn't graduated high school. And he kept watching the physical therapists taking care of wounded soldiers as they came back from Europe and got so excited about it. He got his high school degree. He went to college. He became a physical therapist and went on to become a neurophysiologist studying at the Nobel Institute under a Nobel laureate. And his main interest was the muscle spindle and the silent period. And when I heard his lecture, I asked if I could work in his lab with him. And during my 4 years in medical school, I helped him in his lab, setting it up, doing experiments on spinal cords and putting together basically neurodiagnostic equipment, which carried over into doing more neuro. When I went into the neurology residencies, I was doing electromyography by then. And then during that residency, with an interest in muscle disease, I studied in England under another very famous neurologist who wrote several textbooks on muscle disease. So I came back to Richmond and basically started doing a subspecialty in neuromuscular disease. Then I went into the Air Force for 2 years as a staff neurologist at Keesler Air Force Base, came back on faculty at VCU-MCD, and there basically ran the neuromuscular practice, running the muscular dystrophy clinics and doing all the muscle biopsies and electrophysiology. But I always loved general neurology. Unfortunately, I suffered a back injury trying to ski uphill, holding onto a tow rope. I thought I had hip pain, and I went to an orthopedic surgeon, and he said my hip was fine. And while I was doing an EMG, S1 went numb on my right foot, and I knew why my hip hurt. That ended up with surgery. And while I was recovering, I decided that I wanted to go into general practice. And financially, at the time, it was difficult. We had 3 kids, and salaries were limited in academics. So I just needed to make some money. And so the typical neurology practice that I had was what any other neurologist would have, a lot of headaches, neck pain, and back,
Mhm.
for which we had no training
Right.
other than diagnostics, which, as you might imagine, were always normal. So a back pain patient with a normal neurological exam or a normal EMG would then turn to me and say, well, doc, why does my back hurt? And my only answer was, because your nervous system is normal, you can feel pain. That never went over well. So as it turned out, I did a favor for another neurologist in Richmond who became the president of the Neurological Association, the American Academy of Neurology. And as a thank you, he invited me to a neurology meeting with 50 neurologists from around the country. And the topic was back pain. And a neurologist from San Francisco was demonstrating the standing forward bending test, which I had never seen before. I used to joke, he kept using the terms PSIS, and I kept thinking that was the stuff that comes out of your bladder. What the hell is he doing? And so as I watched him, I said, this man has no idea what he's doing, but he's onto something wonderful. And he said, I spoke to him about it, and he said, we're having a course at my hospital in San Francisco in a few months. Phil Greenman will be there. I had no idea who Phil Greenman was.
Right.
And I said, sure. And so I went to this meeting, this course. It was the only time they taught principles with the sacrum.
Right.
And I always argued we needed to teach the sacrum because that
Right.
was the key. And the first lecture was by Dr. Greenman. And I thought, this is chiropractic. I'm going home. But it was too late and I was jet lagged. So the second lecture, which always turned me on and which I loved teaching over the years, was on spinal mechanics.
Yes.
And I always dedicated my lectures to him on spinal mechanics.
Yes.
And then the story after that becomes amazing because I had all this data. We had everything in loose leaf notebooks. There was no textbook. We had notes. Everything was mixed up. There was no index, no table of contents. You
Right.
just had to keep going back and forth. And on my first day back at work, I had a patient with ocular myasthenia. Her name was Ruby. She was in her 80s, and she was sitting in my waiting room. And as a neurologist, and I always did this through time, I always went to get my patient because I could tell more about their exam watching them walk from the waiting room to my examining room.
Right.
And when I went out, I said, Ruby, how are you? And she said, I'm awful. I can't get out of the couch. I said, what happened? She said, I hurt my back. I said, well, when did you do that? She said, 2 weeks ago. I said, well, why didn't you call me? And she said, well, I knew I had this appointment and I didn't want to bother you. Well, she couldn't get out of the couch. We had to carry her into the exam. And I get her up on the exam table and she's in agony. And I run out and look at my notes. And I run back into the exam room and I'm figuring this has got to be a sacral problem. So I turned her on her side and I positioned her for treating a left on right torsion. And I'm getting her all positioned. And all of a sudden there's a loud pop before I did anything. And gravity took over and her eyes opened wide. And she said, oh my God, what did you do? And I said, I don't know. And she said, well, the pain's gone. And she jumps off the table and starts dancing around my exam room, wiggling and bending. And she said, God, if I knew you could do this, I would have been here 2 weeks ago. And I said, 2 weeks ago, I couldn't have done what I don't know I just did. But that was the key that I had to learn how to do this and what it all meant. From that point on, I took every course that came up. The next course I took was on myofascial relief with Dr. Ward,
Yeah.
who doesn't really speak English. what I've learned in this business, and I also learned this from Dr. Stiles, who, as you know, is a master of functional technique and
Yeah.
studied with the grandson of A.T. Still.
Yes.
And he said that when he approached um, Dr. Laughlin, if he could watch him work, Dr. Laughlin said, "You can watch me, but don't ask me any questions," which also pointed out what a nonverbal skill all this is,
Yes.
and the difficulty in using words to describe what you feel and what you can sense. And so I took that to heart. I would take a course, I would go back to my office, I would use it on patients with back pain or neck pain, take another course, come back with more data. At that time, they had muscle energy above and below the diaphragm, which are
Mm-hmm.
two separate courses. Those were wonderful.
Yeah.
And then I kept going on. I did cranial techniques. I was doing everything and bringing it back. The most interesting story was a young lady who came to me with severe foot pain. She came from Helena, Montana, and was visiting her daughter. And her daughter knew about me and brought her in. And her foot had atrophied. She had several foot surgeries. And extension digitorum brevis was gone. There was nothing there I could see. And the foot was cold. And all I knew was muscle energy technique. And so I worked on her, working on the low back and the lower extremity. And it was still not right. But the next day was another cross the extremities with Dr. Jacobs and the Manel. And I said, hang around. I think when I get back, I'll be able to finish the job. And so I took the extremities course, came back, and brought her into the office. And by then, just by what I had done, extension digitorum brevis had come back. The foot was warm, and it took very little of the high velocity techniques that you learn in the extremities course to mobilize the joint.
Right.
And she walked out pain free.
Yeah.
2 or 3 months later, I got a phone call from her, and she said, "You know, you did 2 treatments on me. You took care of a problem that had been going on for 5 years."
Mm-hmm.
And she said she wondered if she could sue the orthopedic surgeon that had done all the surgeries that didn't work.
Mm.
And I said, unfortunately, you cannot, because that surgeon was practicing the standard of care, and I was not. And I said, I hope someday what I do becomes the standard of care.
Right.
When you
Yeah.
go back into the history of all of this with bone setters, going back to the origination of Dr. Still's work around the same time, around 1860,
Right.
the surgeon that was describing the bone setter said, I hope with our knowledge, we can make this all part of our practice. It hadn't happened then. It hasn't happened now. So
God.
the more I did of this, the better it was. And in 1988, I went to Dr. Greenman and I said, I think I would like to teach. And Dr. Greenman said, do you know? I said, yes. So I became a table trainer. And at that course, I was a principal's course. And Dr. Manel didn't make that course, and he always talked about the differential diagnosis of back pain. And by that time, Dr. Bourdillon, who was also an interesting story because he was an orthopedic surgeon from England, where they started doing manual therapy.
Mm.
And they always did it under general anesthesia.
Mm.
And one day when he was covering for his chief, one of the patients called him and said, could he come over to her house and manipulate her back? And he said, I have to do this under anesthesia. She said, why? He said, because it might hurt. And she said, it can't hurt any worse than it is. Do whatever you can. It'll probably hurt me more to get down to the office.
Yeah.
So he went out to her home, mobilized her spine without anesthesia, and was amazed to see that he didn't need anesthesia to do manual medicine. So he got into his skill set of doing manual medicine. and started teaching at Michigan State, having met the people from two societies, the North American Association of Manual Medicine and the American Association of Orthopedic Medicine, which
Mhm.
are two things he joined and I joined. We got to meet other people in that. So he was teaching along with the principal's course, and he was in San Francisco for the first course that I taught, that I took.
Awesome.
And so I knew him and I knew Phil, and I'm trying to teach this. Suddenly Phil turns to me and says, "Why don't you do the differential diagnosis of back pain lecture?" And I had no preparation, and all I had was Manel's notes, which made no sense to me, and his slides. And as you might know, back in those days, we were limited to the carousel with
Yes,
little slides.
I remember.
And so I got up and I gave some kind of a lecture on back pain. And when I sat down, poor Dylan turned to Phil and said, "He gave a lecture. He's faculty. He's not a table trainer. He gets full salary."
And that's
So
what,
from that point,
uh,
that's from that point on, I was on faculty and teaching. Somewhere along the way, Mark was always taking classes with me. Carl
yes,
was teaching. Mark Bookhout and I were taking courses together. I used to make fun of Mark because when they would have to do a mobilization, he would wrap a towel around his hand because it hurt his hand to put it underneath the patient. So he had a way of wrapping it.
yeah.
There were so many weird people in the courses at that time, but after a while, we all started teaching together, and as you might imagine, became fast
We
friends.
absolutely. And you and Mark went on to do the 6th edition of Bourdillon spinal manipulation as well.
So I wanted to do it, and I started to type Bourdillon's book up so I could change stuff. And then I remembered just before he passed away, he gave me a compact disc, a CD. He said, "Why don't you hang on to this, Ed?" When I opened it, it was his textbook, all printed out. So I had his book, and
Yeah,
from there, editing it was much easier.
yeah,
So Mark and I started doing it. By this time, PowerPoint was coming into play in terms of teaching, and I
yes.
was able to generate slides with spines on it that were much more detailed than we were dealing with. So the pattern that I had was I would take a course, I would teach a course, learn from the people I was teaching with,
Yeah,
go back to the office, apply that to my patients, go back and teach another course. So at that period of time, I was doing the principles twice a year and muscle energy twice a year. And so I was taking the courses 4 times over and over and over again.
yes.
Uh, and I would kept making mistakes and correcting them by what I learned at the course. And then the interesting thing was I decided this stuff is so good, I'm going to do a paper on this, and I'll do 2,000 patients. Nobody's going to argue with the small sample. It took me 5 years, Lisa, to do this study. And the problem I had was over the 5 years, my skill set had changed so much that
Yeah,
I couldn't compare the work that I did in year 1 to year 5. So I
yeah.
couldn't trust my data. But I had 2,000 patients
It evolves. Well, I know.
involved.
Yes.
So that was a significant thing. So my practice became more and more hands-on. People started seeking me out. Um, and I was doing more manual medicine than general neurology, but I was still, up until 1995, I would make rounds in the morning in the hospital, come back and see patients in the office. Some of them needed manual medicine. At night, I would go back out to the hospital, making rounds and seeing consults. So my day went from 7 a.m. to 11 p.m. usually. But the thing I loved the most and the thing that gave me the most fun was the hands-on, the manual medicine.
Yeah, that got you
And the
excited.
patients, yeah, and the patients that I had always hated, the neck and back pain and headache patients, became my favorite patients.
Yes. It's so
And it was
total.
just like, and it was so much fun. It was
Yeah,
fun.
it
It
is. It's
was solving
fun.
problems and you know, and I always would sit back and I would examine a patient, treat them, and re-examine them and say, "Oh my God, this stuff works."
Well, I know. I was just
And I
talking
would
about that. It's
watch
so
it
true.
and re-examine and keep on going. So over time, my practice became much more oriented to manual medicine. So my practice gradually shifted over
To a
to
cash base,
no insurance
no insurance. Yeah.
and no participation. And then the insurance companies, I was in a practice with two other neurologists,
Hmm.
and the insurance company said that if I didn't participate, they couldn't be sure that our credentials were right. They were going to kick my partners out of the practice, out of their coverage. And so we split up in 1995 and I went on my own.
Yep.
And then I also stopped Medicare. So I had a unique practice,
Yep.
cash only,
Yep.
no electronic records. I didn't have to make rounds anymore. I wasn't going to the hospitals. I
Right.
wasn't taking drugs. So I always did neurology as part of the practice, but mostly for musculoskeletal. And if it was a neurological problem that needed coverage, I would refer them to one of my old associates,
Right.
my partners. Um, Now, that also became a problem for me in the teaching
Mm.
aspect
Mm.
because I was one of the few physicians teaching, and most of the classes, were physical therapists.
Right.
And so the constraints of a physical therapy practice weren't anything I had to experience. And I think I had a problem with explaining that. I mean, it was easy for me to do what I wanted to do, to
Yeah.
order what tests I wanted, um, and follow up as I saw fit. I didn't have to follow a set program to
Sure.
satisfy an insurance company.
Right.
So most of my patients did well with one or two treatments, and then they would come back if they had a problem again. But that was the fun of my practice, and I loved it. And every time I taught, as you probably remember, I kept changing my lectures and
Yes.
improving them. And
Always.
one of the best things about we would all sit together. It wasn't during the class so much, although some of it happened there. But after class, we would all get together
Yeah.
and then we would brainstorm and what were we doing? And if we go back and look at the evolution of the classes, we've all. I said we had this loose leaf book that had no index, and then Dr. Greenman published his first textbook on manual medicine, and several editions, as you know, have come out.
Yes.
And so we kind of felt obligated to teach what was in that textbook
Right.
because that would be the only reference
Yes.
that classes would have. And so we would stick to that over the years. But as time went on, and as we looked at things, we said, I don't see this, and I don't think this is as good a technique as we can do. And one of the breakthroughs was they had the idea that manual medicine was like peeling an onion. And as you remove the outer layers, you found another problem. And then we realized the problem was there, we just didn't see it.
Mm.
And that had to do with the mechanics that we didn't quite understand,
Yeah.
that we started to incorporate into the lectures. And of course, Mark would always come up with a different technique, and Carl would come up with a different technique or change a technique that had been used.
Yes.
And then we realized that Dr. Greenman, who wrote the books, maybe didn't treat as many patients as we thought because he would turn a lot of them over to his physical therapist. And a
Mm.
lot of the people that were teaching us didn't do it. We were doing it every day
Yes.
over and over again.
Yeah.
The nice mix was because Mark was so limited in terms of access to him that patients had to be very chronic before they got to him, and
Yeah.
that he would spend a lot of time working on. Carl, going from physical therapy, then became a DO and
Yep.
started his practice was mixed with a family practice, but he
Yep.
was able to see more acute problems. I would have a practice where somebody hurt their back in the morning and they would call me up and say, my back's hurting. And I could say, come on in.
That's it.
So I had no delay in seeing these people unless I was away teaching. Then they would just wait till I got back.
Right.
So we had very different patient groups. Then I had the self-pay group, which is also different.
Yeah.
There was a different motivation. Even the workers' comp patients that I saw were the ones that I didn't participate, so they paid me to get better,
Right.
and not workers' comp. Lawyers stopped using me because I was getting their clients better too quickly.
Right. That's always a problem.
But if I could say one of the things, if you listen into my exam room, what you would hear most often wouldn't be moans or anything, it'd be laughing.
Yeah,
Because we would all
100%.
laugh.
Yeah, I know. That's what I appreciate so much about you. Like I said, is you just make things fun. And then you always came back, whether it was during the course or the next course, and you tweaked your presentations and your slides, and you could take these very complicated principles about spinal, mechanics and put them into a visual where it was like, oh, that's what I was trying to say, and you just
But
showed
there
it.
it is. So the visual, that rather than the words are there.
Yeah, I
Now, the
love
other
that.
thing is my neurophysiology background changed the way I practiced again,
Yeah,
because when people were trying to strengthen weak muscles, and Mark was the first guy that said this, you can't strengthen an inhibited muscle.
right.
So you have to find out what's inhibiting it. And
Yes.
so he would find another muscle, let's say uh, the glute was inhibited. So he would see the rectus femoris was tight. He would stretch the rectus and the glute would fire. I said, wow, that's great. And then I would see patients stretching their hamstrings, and I realized they were stretching their hamstrings because the glute wasn't firing.
Right.
So
Yeah.
I would then fix the rectus, glute would fire, the hamstring would relax. And so all of those things started coming together. But then the most amazing thing that happened to me was the lumbar spine. And I started teaching this. I said, they started teaching that ERSs in the lumbar spine could be treated a certain way. And then we had all these slides and how we treated an ERS in the lumbar spine.
Right.
And one of the things that bugged me was when I fixed an FRS, an extension restriction, flexion improved.
Yep.
I said, why is that happening? So I started really looking at ERS patients, and they have always taught, well, you can't get non-neutral mechanics in the lumbar spine extension. You can only get it in flexion. But the spine will act like there's an ERS. Well, that never satisfied anything. So when I started pushing it, and I started having patients really bend further forward, bless you.
Thank you.
When they started to really bend forward, I noticed what looked like an ERS disappeared. And they were just bad FRSs.
Yes.
So once I started treating those, then the lumbar spine changed.
Yes.
And then the next thing I noticed was, well, I've got a tight rectus. It must be facilitated by an FRS in the lumbar spine.
Yep.
So I thought, well, the L3-4 would be doing it. And so I started going there when I found a tight rectus. Sometimes it worked, and sometimes it didn't. But then I noticed L4 or 5 could also do it.
Yep.
So when I started examining patients with low back pain, the first thing I did with them prone was to see how tight the rectus was. If it was too tight on the right, I looked at L4. And sometimes, more times than not, as my practice changed, if there was an FRS on the right at L4 and what looked like a left on right segment torsion, if I fixed that L4 first and the rectus relaxed, the left on right disappeared.
Yep.
And when you're seeing a bunch of patients, if you could find shortcuts that you don't have to keep doing the same stuff. Now,
Right.
if it was tight on the left, then I had a left on right that had to be treated. But at the end point of treating the lumbar spine, aside from flexion and extension, was relaxation of the rectus femoris.
Yeah.
Was the key that I knew that I had facilitated. I
Yes.
got rid of the facilitation in the rectus, which
Yeah.
then affected the glute, which then affected the hamstring.
Yeah.
So I started stretching very, very little in the way of limb muscles.
Yeah. Yeah. Just treat the
Once I got
source and
the
change the
spine,
input.
so it just became more and more fun looking at the physiology,
Yeah.
because I always knew about the circuits. You have the tiny muscles around the spine
Yeah.
affecting the larger muscles, affecting the larger muscles, affecting larger muscles. So getting that spine to move properly, that was
Yeah.
the fun.
Was key. Well,
Yeah.
that kind of leads me into, I know you get great clinical outcomes, right? And a lot of the stuff that the principles that we teach in the classes is what you do every day. So why don't you share with our listeners, like, your top 3 things that you think have made the biggest impact on your clinical outcomes?
FRS, mid upper thoracic spine,
Okay.
thoracolumbar junction,
Yes.
and lower lumbar,
And sacrum.
and the sacrum. But that becomes a lot easier to do, as you know, once you correct the other muscles that are being facilitated or inhibited. So there's a lot of big muscles that are pulling things around that have been facilitated or inhibited by what's going on around the spine. So I'm always, last year, we went on a trip, London and Paris. And we were in Paris, getting ready to go to London. And one of the tour directors was buying us drinks, and he couldn't raise his arm up to cheer me. And I said, "What's the matter?" He said, "Oh, my shoulder's killing." So in the bar,
Of course.
it was his right shoulder. There was an FRS right at T7, which, facilitates latissimus. And I just mobilized that alone while he was sitting in the chair. And then he could raise his arm up and toast everybody. So I got more free drinks
There you go. It's a good party
doing
trick.
that. But those little things are just, so it's looking at that spine. Now the other thing, and this is the thing that I found that I can give the most help to students with when
Yeah.
I'm teaching,
Yeah.
is how to touch
Yes.
and how far to move the patient. Because I see sometimes, and Carl is guilty of this, because he'll really swing patients back and forth as he's feeling stuff.
Yeah.
But I point out that you just have to, you're just moving like an eighth or a quarter of an inch off the midline
Yeah.
if you're doing lateral translation to find a restriction. And so what I would do most when I was teaching was using my hand on the student's hand
Yeah.
and showing them where the barrier was, and just reinforcing that. And once they could feel that, it was like riding a bicycle. I mean, they could do anything once they generated that skill. The other great skill for hands is cranial cross. Once you can feel cranial motion, your hand skills become much better.
Yes.
But the first question is feeling the diagnosis, feeling the dysfunction, and getting to it, and feeling where to start, where to stop, and where to recheck.
Yeah, absolutely. So, I think what, you're saying is, okay, clearing out the spinal mechanics, and there's definitely key facilitators that create these long restrictors, high tone, and or inhibition, and finding those, making those connections, which is a lot of what we do in the exercise course as well. right, pairing the muscle energy and the exercise to go, okay, where are these muscles innervated from, going there, cleaning up the spinal mechanics. And then once you do that, seeing if you made a change. Is the over facilitated now turned off, and is the, you know, under facilitated turned back on? And then with your setup, it's, you know, getting to that localization of the barrier, and you don't have to go very far. If you've
No.
swung too far over, you've missed it completely. And I would agree that is something that I teach as well.
And you don't need a lot of force. The other great thing that I
Right.
came up with was using eye motion
Yes,
as
you
as
sure
a
did.
technique. And I'm able to use that into the upper thoracic spine because it works all the way down to there, feeling that tension develop just by eye motion. So you can't get more gentle than that. One of the problems I've always had, because I've never been able to do the exercise stuff yet. I took the courses. Of course, I respected all the stuff you were doing and what Mark was doing. But when I tried to apply that to a patient care situation, I found that patients just didn't do it,
Not
or they did it so
compliant.
poorly. They just did it so poorly, or they had, I couldn't believe that what they were doing was what I showed them to do. So that one of the first thing I would say, are you doing your exercises? And they would say yes, and I would say, show me.
Right.
So I ended up coming down to maybe 1 or 2 exercises to do. And if they did that, and they were still having trouble, then I would go to personal trainers. And I actually brought one to one of the courses. She took the exercise course because I found that most of the time, in my experience in the Richmond area, exercises were not provided by the physical therapist. They just showed the exercise and turned it over to someone else.
Yeah, you're right. That in many traditional models, that is how, it works.
And so, and I recall the first time I had back surgery, I went to physical therapy and they showed me what to do, and I was on my own. I mean, and having been a good Jewish boy from Brooklyn, we don't exercise. What are you, crazy?
Well, that is true. And that's, something that,
So I'm so glad you've got this system set up where you can show the exercises, teach, and
because it does
have
make a
something
difference.
for people to go back to look at.
Absolutely.
But I didn't have that available here. So
So
and the other thing is most physical therapists in the Richmond area start their treatment with exercise rather than
the manual.
doing anything else. So that was always disappointing.
I
was also disappointed they didn't take more advantage of me in the Richmond area.
It's true. And, and now we're just trying to spread the word and teach, and how to, improve that, assessment, treatment, and then when you integrate the exercise piece, for sure.
I gave a lecture to a big course in the Richmond area where they were doing all these different techniques. And I just did the mechanical lecture and spoke about it. And it blew the class away, and it shouldn't have.
I know. We just have to, one student at a time, just keep teaching this stuff.
The other funny part in my background was once I started doing this, I went back to and because of the physical therapist that I worked with was on faculty at VCU as a professor of physical therapy, I contacted them and I said, I'm learning some great stuff. I'd love to teach this to your students. And they said, wait a minute, you're a neurologist. I said, yes. He said, well, we can't get the neurologists here to help us. They want to know about multiple sclerosis, Parkinson's disease, stroke. He said, could you lecture on that for us? I mean, that's what we need. I said, I'll do it on one condition. At some point, you'll let me teach spinal mechanics to the students. And I taught 4 lectures to the students over the years. And finally, I said, now I want to teach one course in manual medicine. It didn't work at all because the faculty didn't have a clue about it.
Right. Yeah, that makes it hard.
And the students were, the problem is you find out you need this stuff when you're in practice.
Yeah.
I became a doctor when I was an intern, not in medical school,
Yeah.
when I had to start doing it.
Yeah.
And then all this other stuff, you get to appreciate what you don't know.
Absolutely. Well, this has been so wonderful, and I so appreciate you and your friendship and all the years that, we had the opportunity to teach. I know, moving forward that, you may not be teaching as much, but it certainly has been a pleasure kind of hearing the journey and hearing your little
Yes.
clinical pearls. I always loved your little clinical pearls, and I know that your presentations will live on at Michigan State for sure.
Well, the other main thing is, and I think all students have noticed this, that among the faculty, the
Yeah.
biggest word to describe us is love.
Yeah.
We love each other.
Yeah, absolutely. Yeah, it's a family. Carl and I were just talking about that. And, it's been, 20, I mean, for me with you is over 27 years of knowing you, taking classes from you and then working with you and then having dinner with you and laughing with you and making mistakes and correcting and learning from each other. I mean, it's been a journey, and it's why I kept coming back to Michigan State was because of the faculty. I mean, the information is so great, and rinsing and repeating and teaching and learning, it makes you a better clinician, which I loved, but I love the faculty. I just love teaching with the faculty. So
I'm sorry it's been too infrequent, especially with COVID and all that. But
yeah, I know. Well, this has been great, and I am going to put a discount code in the show notes for anybody who is interested in taking any of the courses at Michigan State. You'll have a link there. And anyway, if somebody did want to reach out to you, that they could, any opportunity there?
well, absolutely. In fact, if they go through you, you can contact me.
Okay.
I'm happy either to do it as a Zoom or
Sure.
I've had students send me questions by email. You have my email if somebody
Wants that. So great.
Yeah.
I'll put that in the show notes. And yeah, that we'll be able to offer that. That sounds excellent. Well, this has been super fun. So
Great.
Thank you so much. And until next time, keep getting great outcomes.
Thank you.